Okay, so we are live now. You want this, Dr. Ahmed, welcome to our platform. This is going to be an interesting talk tonight. We're going to be discussing giant retinal tear. Do you want, Dr. Ahmed, would you like us to pursue this meeting in English or in Arabic?
Well, thank you so much. Totally up to you.
Well, we're going to see how the audience reacts with us. And
زي ما انت عايز يا برنس.
احنا النهارده هنتكلم generally عن انت did you invite a lot of people from the States?
I did invite, but the problem is now it's a working time in the States, so I'm not really sure if there will be like how many people will be joining. I think totally up to you.
Okay. Well, I'll see with the audience.
Yeah.
People are saying let's do it combined, so that's fine. Okay. Let's. I'm not going to be fiddling a lot with البانرز وكده علشان احنا لوحدنا احنا الاثنين معناش حد ثالث يبقى معانا. فانا هحط ان احنا discussing giant retinal tear النهارده and then go back عشان الناس ايه موجوده. Everybody is with us. So today we are discussing giant retinal tear. We're going to be discussing a lot of the pathology, a lot of the physics involved. We're going to be discussing حاجات بقى كتير قوي في why things happen and how we manage things and why we should approach differently, because some people are confused between a lot of situations like giant retinal tear, normal tear, retinal dialysis. So today we will be trying to simplify the differences between anything that is similar and give a simple approach to how to manage giant retinal tear. We're having a good audience right now, so we can start our presentation. First, what is a giant retinal tear? A giant retinal tear is a tear that extends for 3 clock hours, which is 90 degrees, in the presence of a posterior vitreous detachment. And this discriminates the giant retinal tear from a very similar condition, the retinal dialysis. والفرق ما بينهم, the difference is critical لأن ال sequences لeach one is totally different. إيه رأي حضرتك يا دكتور أحمد؟ How do we يعني why there's a critical issue when we come to differentiate between retinal dialysis and giant retinal tear when we see it in the clinic?
Well, thank you so much. This is a very good question. So with that, I think the main thing really is that in dialysis there's no PVD and the vitreous is still attached, while in giant retinal tears, usually in most of the giant retinal tears, there's vitreous separation. And that makes a big difference, because if the vitreous is still attached, the dialysis detachment will not extend so quickly. And then you have less risk of you have a slower progression. You also have less risk of PVR because the tear is more or less closed. And in these patients, they are really best managed by buccal. It's very easy to do buccal, and they do so well. While in giant retinal tears, you have the flap inverted, they need vitrectomy, and the progression is very quickly because the vitreous is separated. Also,
so in a dialysis, we don't have a posterior vitreous detachment, so the vitreous is supporting the retina, and we have the vitreous base is attached to the posterior lip of the retina. So we don't have an axis between the retinal pigment epithelium and the surface of the retina, and that makes the risk for PVR much less.
Yes.
So we can summarize it. The difference is the mobility of the flaps, the retinal pigment epithelium exposure, and hence the risk of having a PVR. Okay, so what makes a giant retinal tear so special? Like, why do we have to discuss giant retinal tear and not discuss horseshoe tear? What makes us always want to make a special case of giant retinal tear? And if we have a case, we want someone who is more experienced and more more capable of performing vitrectomy in these cases. I would say at the beginning, it leads to expensive RD. So that's why we always think it's an emergency. If you leave it, the RD, the retinal detachment increases and gets more extensive. The posterior flap tends to roll over and fold and even invert in some cases, like in this photo, the lower photo. The risk of PVR because of the exposure of the retinal pigment epithelium in all this area, and it has access to the anterior surface. It's a very challenging surgery because of the mobility of the anterior. We will discuss the challenges that we have with it, and it has a lot of common complications intraoperative also, and it has ocular and systemic associations. There's a lot of ocular associations like lattice, myopia, several other, the association of the fellow eye. The fellow eye frequently gets involved, and we have a frequency of getting a giant retinal tear in the fellow eye also. And redetachment after surgery is a very common issue. If we want to classify the giant retinal tears, we can classify it according to various classifications. We can classify it with the location of the giant retinal tear, which is equatorial, or equatorial with posterior extension, or oral. I think the oral is the least common, Dr. Ahmed, don't you think so?
I think so. I think so. They're usually like not so oral, but yeah.
Yes, it's the least common form is the oral, which is very anterior. So and it's more common to be equatorial or equatorial with posterior extension. The etiology can be idiopathic. The etiology can be idiopathic. It can be traumatic, following trauma, whether open wound trauma, closed wound trauma, surgical trauma. It's whether it's vitrectomy, cataract, complicated cataract, or even refractive surgery. It could be lattice related. It could be iatrogenic with heavy diathermy, heavy laser, pars plana vitrectomy, as we said, like cataract surgery or refractive surgery. The other classification is according to the configuration itself. So we can have a giant retinal tear without an RD. And this is like in these cases, Dr. Ahmed, if you have, Dr. Ahmed, are you still with us? All right, let me add you to the stream again. Sorry, I think I lost you.
I dropped off.
Okay. We classify also according to the configuration. We have giant retinal tear without RD, and this is very uncommon. We have a giant retinal tear with RD at the posterior flap, like it's a trivial RD, or rolled posterior flap. We have a rolled posterior flap like here, or inverted posterior flap. We have an inverted posterior flap like here, or we have a posterior flap with posterior extension. We can see the posterior radial tear here, so the giant retinal tear is here, and then we have a radial tear that is extending posteriorly. So I would like to point out in these photos the fact that a lot of people think that the giant retinal tear looks, all the giant retinal tears looks like this graphic picture, which is the vitreous is in the middle, and then we have an RD with a large detachment. When it's actually this B-scan shows that you can have vitreous behind the retina. This is very interesting. Dr. Ahmed, I lost you again, and then I have you back again. Sorry. Okay. So this is a very nice B scan that shows an inverted retinal flap, and it shows you that you have vitreous behind the retina. So let me show the next slide. I think in the next slide I can show something interesting. Like this is another images that show not all giant retinal tears look like this, but giant retinal tears will get inverted and covered with the posterior vitreous, which is detached. So that's why we say giant retinal tears have posterior vitreous detachment. Okay, let's discuss quickly here the fellow eye. Dr. Ahmed, do you usually treat the fellow eye in patients with non-traumatic giant retinal tear?
Actually, I don't. I don't do any prophylactic treatment in retinal detachment unless there is really something obvious to treat, like a horseshoe tear. But I don't even treat letters. Just my sincere advice: if you are to treat, I would just use a buckle. Don't do laser or cryo. Use an encirclement if you are to do something, and I wouldn't do laser or cryo.
Well, what I read is there is no absolute proof that a 360 laser preventive measure gives any preventive addition to the fellow eye, so we wouldn't do that. But again, there is a criteria for high risk in the fellow eye, which was made by Freeman, and these criteria were high myopia, white without pressure, vitreous-based condensations. And if you see that, then I think we need to follow this patient closely, and maybe we can offer the scleral buckle, but I think a scleral buckle is a very radical surgery for an eye that doesn't have a detachment. So maybe we can just follow. I want this video. I'm going to show this video. It's a very nice video that shows we're doing vitrectomy here, and you can see the vitreous. We're doing actual core vitrectomy, and the retina is inverted. It's like there's a fold of retina that is totally inverted, and I'm doing vitrectomy behind the retina. And now we're going back to reducing the retina to its normal position. As there's a lot of other tears, and then we use the PFC to reduce the retina back to its normal position. So we have a lot of motility in the retina, and we have vitreous behind the retina, and a large area of exposed retinal pigment epithelium, which is, as we said, is a high risk for PVR. So the challenges that we face with the giant retinal tear, Dr. Ahmed, what do you, in your opinion, what's the most critical challenge that you feel is very challenging for you in the surgery?
I think the slippage.
The slippage.
I think you can manage. I mean, it's if you have the concept in mind that you have to like manage the mobility and the anterior horns, then if you just understand that these areas need to be, these two issues need to be managed, you manage them. And the PVR, there's nothing you can do really.
Yeah.
We'll have to leave this in an upper hand. So it's really mainly the slippage.
The slippage. So the main four problems that we have in the giant retinal tear surgery is the posterior flap motility, the anterior horns of the giant retinal tear, and the posterior flap slippage. For the posterior flap motility, Dr. Ahmed, what is your strategy in managing the too much motility in the posterior flap?
So, do you mean during the surgery or?
Yes, during the surgery.
Like everyone else, I would use PFCL. So I would start like you very nicely showed doing the vitrectomy, I would use canalopy. I always use canalopy in detachment, although most of these patients have vitreous separation, but I think it's good to use to not to waste time and find that some patients have vitreous crisis or do not have vitreous separation. Then after that, once I'm done with this, at least in the posterior pole, then I will use PFCL to put the flap back. That's what I would do.
So you use the PCL after you have finished all your vitrectomy?
No, not necessarily. I think at least after you finish the posterior vitreous separation. You can put a bubble of PFCL and then do more vitrectomy and then top up. So either or. And
what do you do about the anterior flap?
So anterior flap, I usually remove it.
You usually, even if it's if the tear is anterior and you have a very big anterior flap.
No. So if it's really, so I come and go about this, but if it's very, you mean posterior, right?
Sorry, I said anterior.
If it's very posterior, I'll try to sacrifice the retina and laser it down. But if it's not too posterior, as you would expect, then I would remove the anterior flap.
Okay, well, yes, I think I would agree with you with this, because if the tear is posterior, then we have a very huge part of the retina that if we excise, we're also exposing a lot to a huge part of the retinal pigment epithelium, and we're going to leave it bare. We don't know what's going to happen after that. And if we leave it without it's not going to be viable. So it will lead to proliferative changes also. So I think it would be fair to say that we would laser it all down all the way. So it would be stuck to the retinal pigment epithelium and the choroid, but still covering them without exposure.
So just to add, I do what I do in any other tear. So if I have a peripheral tear, I usually, during the vitrectomy, I would remove the flap. If I have like a big posterior tear, I would just like clean around it and just laser it. So yeah, so I totally agree.
Okay. Do you have any hints about the injection of PFO?
About the injection of PFO?
Yes, during the injection of PFO.
Yes, I can actually show a video.
Okay, please do that.
Let me just get my. Sorry, 1 second. So I think the usual things like, you do it slowly. Let me just, I'm trying to get the video.
Okay, as you get the video, I'm going to play this video.
Yeah, go ahead.
I have a video that, I don't know if I should play this one or the next one. Let me play this one. I'll play the right way and then I'll play the wrong way. Okay, so here, injecting the PFO, I can see, we inject it slowly, and you inject it posteriorly, first near the optic disc, and then you start coming up with the bubble, but maintain yourself inside the bubble and slowly injecting the PFO. This is what I recommend for doing. Are you ready with your video?
Yes. Okay. Yes.
All right.
So yeah, this is just from a video book I did for Springer. So here, this is actually an interesting case. This is a patient who had dropped nucleus. And the patient was wheeled to my operating room from next door. And you remember we always say don't fish in the vitreous when you have a dropped nucleus, because you can have a tear, right? Mm-hmm. And this is actually a giant tear and hemorrhage after removal of the dropped nucleus. And that was present from the start. So likely what happened is that they fished in the gel trying to get the dropped nucleus, and that resulted in giant tear. So the message read, never fish in the gel.
Never fish in the vitreous, yeah.
Always your family tells you if you drop something, go and get it, but that does not include dropped nucleus. Right. Okay, so here, this is actually in a way a bad technique because I have fish eggs, but initially it's fine to have that and they coalesce, but make sure you get a bubble and try to inject in the bubble. And if you have fish eggs, just touch them with the cannula and get them to coalesce. And I try to inject over the nerve and inject from a distance because the PFCL can go into the retina. And this is the dual bore cannula. And if you don't have a dual bore cannula, then I would use a 25 gauge with 23 gauge setting, and that will actually lead to some leak.
Okay.
Because otherwise the pressure will go high. But this is a dual bore cannula, and this is the retina is not so detached, so you just inject and get the flap to unroll, and then it pushes the hemorrhage as well. But if the retina is detached, and I have another video for that, you want to try to fill the attached area first, and then the detached area. And you want to try to rotate the eye a bit so that the bubble would like stream roll or iron the retina as the retina becomes flat. So I remember my boss teaching me saying if you have the tear up, then as you inject the PFCL, roll the eye down.
Yeah.
And then so it like fills the detached area later.
Excellent, excellent. That's a very nice tip. It's a very nice tip. So if you don't have the double bore cannula, you use the 25 gauge in 23 gauge system.
Yes, especially if you have and I think it works even with valve, but I've never done that. I've just seen a technique article on it. We always have the dual bore. So
yeah. Well, we don't have that readily available here with us. So what I do is I detach the irrigation line and let the fluid come out gently from the irrigation line as I inject the PFC. Because if I don't do that, that's true. I can see the pressure going very high, and I can see the disc going pale, and the artery stops pulsating after a while.
yeah.
So this is a nice trick for people who don't have access to an expensive tool like that. Okay, do you have any other video to show on this?
Yeah, no. So on PFCL or other steps? Or
well, let's finish the PFCL because I want to show a video here.
Yeah.
That's very interesting. If you don't follow the right way, this is what happens. This is a patient that had giant retinal tear, and the vitrectomy was going well, and you can see the whole retina is detached. A very big retinal tear with multiple other tears, tackling the anterior rear flap, and then tackling also the vitreous detachments. Vitreous attachments to the other tears. Eventually, we get to the PFC step, and the PFC is injected very fast from far away, as you can see, and you end up with what you see here. Can you see this dome shape? Sorry. Let me get it again.
Yeah, no, it's very obvious, Wael.
Okay, I think I did something now that my presentation has frozen. Anyways, so I think my presentation has frozen.
But
do you have anything else to present?
It's frozen on the correct slide. Yeah.
Okay.
Here.
Can you present another video?
So yeah, I think this is a good point. So inject from far. I would shoot for the optic nerve, although some people argue that shooting an optic nerve might not be a good idea. But most people I know would shoot aiming towards the optic nerve and not the retina. Shoot from a distance. Do it slowly. Even if you get fish eggs initially, fine, but get it to coalesce. And the important thing as well, which is usually not the case in giant retinal tear, but maybe if there's PVR, you want to try to relieve the PVR at least initially and put the perfluorine, because if you shoot over PVR, it may then just go under the retina. It will across the retina. So make sure you really relax the posterior retina if there's PVR, put the PFCL, and then continue to relax and add more PFCL. Okay, so let me, this is here the case, so filled up. And then laser, but let me show you from another, this is a complication as well that is even more dreadful than Wael showed. These are complications that can happen from PFCL, subretinal PFCL, which is not a big deal if it's not too big and you find it after the surgery and it's not in the center. Retinal slippage and retained PFCL are the main complication. This is a case for you where we ended up with PFCL under the fovea. And that's not a surprise because this is the most dependent area in the eye. And one of the reasons that they can happen, speaking about PFCL, this is a patient here with a very high mobile retina to start with. So I use PFCL to support the posterior retina. And now I'm trying to find the tear and indent. And what happened is sloshing, because you're indenting and then removing the indent quickly. The PFCL surface tension breaks and you get sloshing of the PFCL, which is itself not a problem. You can just touch it, but the problem is the bubbles can go under the retina. Okay. So the message really, try to decrease the indent under PFCL as much as you can. If you do it, indent slowly, and most important, relax slowly.
Release slowly, yes.
Because you don't want the PFCL to slosh.
That's true. That's true. So the next, we think that the next challenge. Do you have any other videos?
I have a video here with a giant break, and now this is a difficult one. It's a detachment and the rolled edge, and it's the same concept really. So you inject over the disc. Initially, find a few bubbles, then they coalesce, and now you just go into the bubble and follow the bubble, and just do it slowly. Try to roll the eye the other way, especially if it's detached, and you may even rotate it a little bit. And now the PFCL just pushes the retina back. And as you can see, very important, even if you're a very good and confident surgeon, to make marks with the diathermy. Because when the retina flattens, you don't know what's the view going to be like. And you can see here the marks.
Very nice.
And usually what I do, even if I'm going to go to air, I would cross the PFCL, the tear with PFCL and laser under PFCL.
Okay.
Yeah.
Very nice. Very nice. So let's talk about the laser, the horns.
What do you think? There's a question here from Dr. Harnell, Muhammad Harnell, about phaco-vitrectomy or just vitrectomy.
So the preference, whether it's combined or do you do phaco? Well, I don't think that we need to do phaco in all. We don't need to do lensectomy or phaco in all cases of giant retinal tear. We can do it, my opinion is we can do it with cases that are a little bit too anterior, or if there is a cataract. But I think we can do without the lensectomy. What do you think, Dr. Ahmed?
Yeah, no, I agree. I try to keep retinal detachment very simple, and I don't remove the lens unless it's interfering with the view.
Okay. All right. And you can, if you have a problem with the laser, the peripheral laser or anything, you go on gas, and we have the curved laser probes that can prevent any lens damage. Okay, so lasering the horns. We have difficulties with lasering the horns. What do you think, Dr. Ahmed, about what's your technique to overcome the difficulties with lasering the horns?
Yeah, so that's a good point. Let me just put my well, can you get my video in?
Okay, I'll put your video in again. All right.
Thank you. And so here we injected the PFCL, then laser a few rows. I usually do about 2 to 3 rows. And then I would indent and use illuminated light. Few thoughts here. First, to avoid the sloshing, you can actually complete this step under air if you're going to go into gas or oil, right? The advantage is that, as you alluded to, you see a better view under air, and there's no problem of sloshing the PFCL. There can be a disadvantage if you have an artificial lens with an open capsule, because your view might not be very good under air. So maybe then don't do this under air. Try to finish everything before going to air. If I cannot reach them with illuminated laser, especially in phakic patients, usually you can do cryo. Is a very good idea, and a little bit of cryo is actually very good. It's not going to cause much PVR. Too much use of cryo is not good, of course. And you don't need an assistant. So I would, but very important, as Dr. Wael is saying, to treat the horns.
Okay. So what I wanted to point out here in this diagram or this graph is like this the presence of fluid in this area. So the horns, they're not 100% coapted. And you have to put that in mind, that you might have a small film of fluid under the retina surrounding, above the PFC that you have. So in order to do to have the retina coapted on the choroid, and then get, and the retinal pigment, of course, and get your laser to mark, you can use several tricks, like Dr. Ahmed Sallam said. First, you can tilt the eye towards you so that the PFC is covering the horns itself, and then you start the laser. Sorry, do you still see me? Oh, sorry, I didn't. I was pointing things that people didn't see. Okay, so again, this is the area that I was talking about that has subretinal film of fluid that will prevent the laser from marking at the horns. So what you do is you tilt the eye towards the giant retinal tear, and you get this area to coapt. Of course, you need to dry the fluid as much as you can. The other method is you can fill the whole globe with PFC. Dr. Ahmed, do you prefer filling the whole globe with PFC while doing your laser, or you don't like to do that? Do you find it easy, or do you find it handy, helpful?
I try to cross the tear and cross it a bit more so that the horns are covered. But I don't try to really fill the whole globe and do like what was advised by Dr. David Wong, because the problem is, whatever you do, there's always going to be fluid. And I think you were going to be wasting too much PFCL and time. And whatever you do, there will always be fluid when you go to air, and you need to really manage that, or when you go to oil. Okay. So yeah.
So why do you think it's risky to put the PFC, take it above the giant retinal tear and fill the whole globe with it if you're not being very careful about it? I think the answer to that question is, if you have your irrigation jet opened and the stream of fluid is coming into the eye, the problem is that breaks the surface tension of the PFO. So, and that makes it go into small bubbles at the surface, which will eventually go subretinal. Even if you try to stop it, it will go subretinal, and then you end up with subretinal PFO.
Yeah, that's a good point, because you're getting nearer to the infusion.
Exactly.
Yeah.
So the first technique is the tilting, as you said, Dr. Ahmed. And the second technique is to fill perfluorocarbon above the tear, but you have to be very careful with that so you don't get near the infusion. And you can do it after the fluid air exchange, as you have mentioned, Dr. Ahmed, and you can do the indentation. Indentation makes the choroid come closer to the retina, and we can use cryotherapy. There are people that agree with doing cryotherapy for the horns, and there are people that find it sometimes debatable. What do you think, Dr. Ahmed? Do you do cryo to the horns?
Yeah, I think a little bit of cryo is very good. I mean, if I cannot do it really with the illuminated laser, I would do cryo under air. I think I use cryo as detachments. Upper break, I cryo them. It's very quick. It's very nice. I mean, my main problem is to find a cryo machine that works all the time.
Okay. So why do you think people don't like it sometimes?
I think I feel it's a myth. Really, people think of a cryo as like a taboo, and and I really don't agree. I think that many of the UK surgeons just use cryo for 1 or 2 tears during detachment. I don't think the risk of PVR is significantly high if you use it really carefully.
You don't think that cryo next to the horn would induce dispersion of retinal pigment epithelium, and that would increase the risk?
I think really very little. I think this is completely overplayed, and but I wouldn't use cryo for the whole giant tear. I would just use it for a horn. It's like one just ice ball on each side, and I think it would save the day.
Excellent. Excellent. So the advantage of the cryo is that it's effective. Even if you had a film of fluid behind the retina, it's still effective. The disadvantage is some people think it would disperse the retinal pigment epithelium and cause induced PVR. And not everybody agrees with that, but well, it's a debate that we all hear about. Okay, so slippage. Now we're done with the horns, and now we're talking about the slippage. So let me show you this video of slippage. While you are removing the perfluorocarbon, this is what you get. The retina slips down. You get a slippage in the retina. Dr. Ahmed, why is slippage a problem?
So you're going PFCL air, right?
Yes.
So I feel like it's very hard not to get slippage when you go PFCL air, and it's more common that you get some degree of a slippage. There's always this bit of fluid. The PFCL is really touching the retina down. The air is lighter. As the PFCL join the air wants to jump up. The PFCL is supporting the retina, and as the air goes and replaces the PFCL, there's a bit of time where the air just jumps up and slippage happens. And I feel it's very difficult really to avoid. Sometimes it's very minimal, I don't see it. Even this one is not too much, but sometimes you can have it really bad. So I think it's the problem with as the air replaces the PFCL, and as the air is filling in, the air just wants to jump up. Okay. And that's the point where slippage happens with any residual BSS.
We have a good demonstration of the physics and dynamics of the slippage that I will show in a minute, so that everybody would understand why slippage happens. But what do you do in a case like in this video, a very trivial small slippage?
I think you can leave it, or you can do a drainage retinotomy in it. I mean, I would not repeat the exchange again. I think if it's peripheral like this, I probably would leave it.
Okay, if you decide to leave it, now we have a problem that we did our laser, and then our laser marks in the retina are separated from the laser marks in the choroid and the retinal pigment epithelium. Do you do laser again?
That's a good point. I probably would not.
You wouldn't do laser again, not even online?
I probably just leave it like this.
Okay.
I think, it's like cryo. If one edge is touched with the cryo, it's fine. If you just touch only the RPE, the retina will stick. And I feel you've done several rows of laser. So yes, some rows might not be in, touching down, but the others would be. The problem is there's fluid underneath. If you want to re-laser on it, it would be difficult, right? Because it will keep popping. So I think if you laser, you really need to indent significantly to try to approximate, because otherwise when there's a significant amount of subretinal fluid, then the laser would make holes. So again, something to just keep in mind as you're doing that, if you decide to laser.
Okay, very good, very good. Okay, so let's go to the next.
What did you do in this case, or what did the surgeon do?
Well, no. Then in this case, we did another row of laser.
Another row of laser. Okay.
A row of laser. Okay. Look at this case, This is a case where we had like slippage that you don't joke about. So we did the vitrectomy, very mobile retina. As you can see, vitreous behind the retina too, and it's a fluid. You do the vitrectomy, the core vitrectomy, you get rid of the anterior flap. I'm not going to tamper with the speed of the video because that makes my presentation freezes. So let's watch it. And then we put the PFC. As you can see, multiple bubbles, but they get together quickly. And the retina is reduced. Still mobile, and a iatrogenic tear in the retina. Trimming of the edges of the rolled over retina. And then the retina is still not on. And still, I do PFC air exchange. That's like a big mistake. Why would you do that? So we get a huge slippage. Huge slippage. Look at this. It's you can't leave it. So we try with the tenon scraper to reduce it. It doesn't work. It's very huge. There's a lot of fluid under it. So we try more. But eventually, the right thing to do in this case is to start all over again. Put it on fluid, and then start all over again. And then you will see at the end of the surgery, everything was perfectly executed at the end. And the retina is on, and everything is fine. But the problem is, to do the surgery again, look at this. The view is totally different. It's like this is elongation of the procedure. The retina is on, the laser is on, and everything is fine, and the outcome is good. But the view is totally different. It's not the same as the surgery you were doing at the beginning. So it's better to get it right at the first time and not get the slippage. So the best thing for slippage is not to happen. The message is you need to avoid the slippage. So how do we avoid the slippage, and why does the slippage happen? The physics that you have just so elegantly described, Dr. Ahmed, we will show it with the images here. As you can see, this is the bubble of PFC, and this is the air bubble. Both of them are hydrophobic, so both of them have curved surfaces. And when they meet in the middle, and they still have, as you can see here, like a meniscus of fluid that's still trapped at the periphery of the eye. And the periphery of the it is where the retinal detachment is. So your tear is here, and the detachment used to be here. So when it goes down, you can see the fluid part. This is the part with the fluid, and you can see that the retina. Let's enjoy it. The retina detaches here, and as the retina detaches here, the fluid comes behind it and takes the retina with it downwards, and slippage happens. So the first thing, how do you want to avoid slippage? You need to get rid of this fluid meniscus. You need to make sure that you don't have this fluid meniscus. How do you do that? We have 4 techniques to do that. The first technique is obsessional drying of the edge of the perfluorocarbon when you're doing the air exchange. Direct perfluorocarbon oil exchange, total perfluorocarbon fill, or short-term post-operative perfluorotamponade. I'm going to show some pictures of the first option, the obsessional drying, and then I'm going to have you, Dr. Ahmed, tell us about the short-term post-operative perfluorocarbon tamponade. So here in this image, it shows us as we do the air exchange, you see the perfluorocarbon at the periphery. The fluid meniscus would look like a dark ring because the perfluorocarbon is very hydrophobic. And if you go at the meniscus and start aspirating, once you get rid of the fluid, this ring disappears, as you can see here. Here we have the black ring, obvious, and now it disappears when the fluid goes away. And then you go all around the eye. You go around in the periphery next to the retina to dry the fluid meniscus all over in every position. And then you aspirate a little bit of the perfluorocarbon, make sure that there is no fluid meniscus around you, and excessively do that. Let's see a video that shows this. As you can see, the aspiration is at the edge of the retina with the perfluorocarbon, making sure that the fluid meniscus is aspirated. And then when you do the perfluorocarbon in the middle, no slippage happens, and it's a very nice view. The retina is on, no slippage. Dr. Ahmed, do you have videos for us that show?
Yes, I do. I was just trying to get it ready. Yeah, if you want to kick it in, Wael, please.
Okay.
Okay, so this is the patient here. So remember, one thing to remember is always make diathermy and mark the tear, because you want to make your life easy. For me, retinal detachment, I try to make it as simple, as easy as possible. So even if you're a good surgeon, do some marks so you can see it well. You don't know how the view is going to be like. And I'll show you how big is the pupil in this case. So here, PFCL attached. Now I cross more than the tear a bit. And now I've lasered, and this is the exchange. So you get the air in, right? So you go on top of the PFCL and get the air in. And wait until you get the air in. Now then, go and go now in the interface. So once you get the air in the eye, you go to the interface, and you wait for the air to come. And here you're just at the edge of the giant retinal tear, and just be patient. And I think I like what Wael said, obsessional drying. So, and keep going, and keep drying, and keep drying, and keep drying. And the trick really to know that, there are two tricks. One is that you find the edge of the tear while the air is coming in and the air is in the eye now, is really on the RPEs. Like you have a carpet, and now the carpet is really nice on the floor. That's one trick. The other trick is that the bubble itself, you're now like seeing the air separated from the PFCL, that you start seeing that the bubble of the PFCL is dispersing, or you're not seeing the convex surface anymore. And we talked about that on the Facebook page, and we said that the bubble of PFCL remains as a nice bubble and looks more like a bubble and more convex when you have fluid in, because the PFCL is very hydrophobic, it shies away from the fluid. But when you're removing the BSS, it is less really convex.
Well, I'd like people to remember how it looks in the bottle where you get it. If you put it in the bottle, you can see it has almost a flat.
Yeah, that's a very good point, actually. Very good point.
But in the eye, it looks like a ball. So in the eye, it looks like a ball because it's very hydrophobic. It has a high specific, like the way the specific gravity is high, but it's also hydrophobic. The surface tension is high, and it's more hydrophobic, so it makes a bubble shape. But in the air, it's more flat.
Yes, I think that's a great point.
Very nice video.
And I'm trying to just get the video from the one that we talked about, the bubble as well. Okay, sorry, I've
perfluoro is with oil.
I'm sorry, I've lost the screen. Just 1 second. I was trying to get the YouTube video we're talking about. I've lost the screen. Okay, yeah. So here, so dry. And then when you really know it's dry, now you go to the disc. So we're still PFCL air, dry. And then you go to the disc, and then you can see the bubble really coming in. And you just follow it. And then you can wait a little bit and then put some BSS in the eye, and then just rock the eye a little bit. It collects more PFCL and then dry it up again. If you think you have some PFCL bubble remaining. And actually, this case, this is the pupil in this case. That was a trauma patient who had pupilloplasty, so it's a small pupil. So things can get difficult. So you want to make sure to make things simple as much as you can and mark. Okay. Well, do you want me to show the
Giant PFCL silicon exchange?
Do you want me to show the PFCL one, the one we were?
Yeah, sure.
Okay, let me just the PFCL bubble one. Sorry, let me share my screen. Okay, so this is the video where I was alluding to, or the discussion we had. And here, as you can see the bubble. This is a posterior brake tractional rheumatogenic. And you can see here, as I'm draining, the bubble is really looking nice. And then as I keep draining and take my time more, and I'm trying to get the retina really flat as much as I can, and I'm seeing the edges. Now see what happened? The PFCL bubble edge just disappeared. And it's not that all the PFCL suddenly was removed. It just, I cannot see it better.
Exactly. We had this discussion over this post.
Yes, and that's why we're not seeing better, because we're removing the BSS that makes it look better. And then actually, I have the rest of the video, but not here. Then I waited a bit and put a few BSS and shake the eye and then removed it again. Yeah.
Excellent. Okay, so now I'm going to talk about the physics of a direct PFC silicon exchange. And then, do you have a video for us, Dr. Ahmed Sallam?
Yes, I'll make that ready. Thank you.
Okay, very good. So when we do direct PFC silicon exchange, in this situation, the silicon and the PFC, they don't act like the air and the PFC. They are both hydrophobic, but they are and the BSS, or the fluid-filled eye, is the fluid is hydrophilic, of course. So the PFC and the silicon, they form not in one bubble, but they interact together. They fill in together. As you can see here, people expect to see PFC down and then fluid, and then because the oil is lighter, it has a very light specific gravity. You can see it in floating above, but it doesn't. It actually collides together with the PFC. Of course, this image is exaggerated. This space is exaggerated. It's a small space that it shows here, but it shows you that the silicon gets in touch with the PFC, and they become one unit, and they how do you say it, kick out the fluid to the side, and you keep aspirating the fluid from the side, and the silicon comes in until the fluid is totally aspirated, and then you aspirate the PFC as a bubble inside the silicon. This is a very quick, small video that shows this. As you can see, the PFC is filling. And then this is direct PFC silicon exchange.
That's very nice exchange.
Dr. Ahmed, do you have your video ready?
Yes, yeah. So let's talk about the passive exchange. So, Wael, how did you do this passive exchange? This is a passive, right?
This is passive with the flute needle.
With the flute needle, okay. So 23.
So I'm relying on the pressure of the silicon to extrude the PFC.
Okay, so if if you can, Dr. Wael, if you can just get it in the screen. Yeah, okay. So, what's the problem? What's the problem with so we heard that direct PFCL silicone oil exchange is really very good, because if it's done properly, it's like 100%. You're not going to have slippage. You just cannot. The physics are very good. They're both hydrophobic. They love each other and they kick the fluid out. So it just doesn't happen. The problem is, so then if this is the case, why this is not a very popular technique and why it's not taught in fellowship, etc. Because it has problems. So the advantage of avoid slippings, actually you get better silicone oil fill. It's very efficient. You cut one step, and the visualization is very nice. As you've seen Dr. Wael's case. The problem is there's a learning curve, and the IOP spike that happens, it can be really very dangerous. The eye can get very high pressure that can cause problems, up to pushing the oil in the anterior chamber in a phakic eye through the zonules. You can also there are cases reported of rupturing the eye. You can rupture the eye.
True.
So then,
they're myopes and they can have a
yes. If you have cataract wound, it can open up. So it's really dangerous if it's not done properly. But why is that? Why is this problem? This is a very nice picture just to show you what happens in the eye. So here you need to get the oil in, right? You need a trocar to get the oil in. You need light, right? And then you need access to remove the PFCL, and that's in all techniques. You can replace that here, the silicone oil infusion through the cannula, and be more efficient and inject the oil just with your hand if you have a chandelier. So that's another arrangement, right? Which is nicer because it's quicker, because the oil doesn't need to go through the tube. And you can do it with 25 gauge, because injecting oil with 25 gauge through that tube can be difficult. But remember, you have to have light pipe, you have to have an access, or you have to have light, you have to have an access for the oil, and you have to have a port where you suck the PFCL, which you can do passive, just with a flute, or active. So let's talk about the passive, which just Dr. Wael said. And maybe let's see what he does. So Wael, you have a light pipe in your hand, your oil is going through the infusion, right? And here you have a 23 flute needle, right?
Yes.
Okay. Then let's see this arrangement. So, sorry, I think what happened is what you just said. Well, don't fiddle much with your videos. Okay. The first thing I did, which actually I learned from my friend Abdullah Laben, we worked together, and actually I didn't used to do this. I get the infusion out and I prime it with oil, and then I put it back, and that gets rid of some of the DSS, right here. So now it's primed with oil, and then I would then start pushing oil and go with the back flush. Here, this is a case of multiple tears. One of them was very big. Now the PFCL inside the eye. The oil is being injected. And we have like a giant tear with a radial extension. The oil is now being injected. Here comes the oil. So you want to go, as the oil comes, you want to go under the oil to the break. And if you have a break, you best be more on the anterior edge of the break. So at all times, the back flush needs to be either in PFCL or BSS, never in oil.
Never in oil.
So remember, the back flush doesn't go in oil. Yes. That's a very important point. So whatever technique you're doing, back flush, never in oil. So what I do is I get the oil or I get the air. Same thing, you get the air first coming, and then you go to the break. And you want to be actually on the anterior edge of the break. With silicone oil, you can be at the posterior edge of the break. It will work well. But ideally, you want to be at the anterior edge of the break to catch the fluid early out. Right? So here I'm at the posterior edge of the break. But the more ideal, you'll be more at the anterior edge of the break to catch the fluid earlier. And then you want really to just keep sucking. You're now in the BSS, PFCL, until you get the oil. Once you get the oil reaching to you, then you start moving with the bubble, and we'll see it now. So here it is, right? Now wait, and then I would just go with the bubble backwards. And that's the passive technique.
Very nice.
Ideally, you want to get this bubble over the nerve and remove it over the nerve, but the problem is the retina usually doesn't do what you want. And usually it's not over the nerve. So you can take it over the retina, but just be wary. So I have a few tips here. One tip is the last bubble. There's a worry that because the pressure is high from injecting the silicone oil, if you continue to inject to get the last bubble, then you will get the last bubble and the retina even can jump to your backflush. So one tip is the very last bubble, stop injecting the oil and press on the sclera with a finger. That's actually usually more controllable.
I actually stop injecting, and I consider the pressure is enough. I stop injecting, and I wait, and it will come out.
Yeah, that's actually even a better trick. So stop injecting. You remember the backflush never in oil, never in oil, and stay still. And then if it doesn't come, it will come. If it doesn't come, then just press a little bit.
Exactly.
So that's even a better way of saying it. Okay. Now my question is, so why the passive method is bad? And you can see here the disc is pale. It's a physical system. You're injecting the oil actively and you're passively removing the PFCL. So understandably, you're running into a situation where there's high pressure in the vitreous cavity. That's what happens. So can we do this actively? Yes. And that's another method. I just have a tip here, especially for beginners who want to do direct exchange. One very nice tip really is to get a mismatch between the infusion and the removal. And that will avoid the high pressure. So what I used to do is I would inject through a 23 gauge system, but the backflush would be a 20 backflush through a sclerotomy.
Okay.
And you really don't have high pressure because you're correcting for what's happening. And I think this is fair enough because an oil is best to suture all ports. So I would open the conjunctiva, get this 20 and put a backflush. And if you don't have a backflush, you can have a large, one of these draw-up needles. And then it's a passively working. And because of the mismatch that you've created between the infusion and the aspiration, your actual risk of high pressure is very low. And I feel this is a nice tip for people who are just trying the direct exchange for the first time.
Yes, this is a very good tip. Very good tip.
Okay.
Dr. Ahmed, the tamponade, what do you use for tamponade usually?
So I'll tell you what I do. I don't know if you want me to tell you now or after we discuss the active message as you like. I use PFCL or gas.
Oh, sorry, I interrupted you. You were just going to. Okay, let's go back and let's go back to the active extract.
And this is the active method. And again, I learned actually this from Abdullah. I didn't used to do it. And I used to do the passive method my way, like what I told you, and I was very happy with it. But then Abdullah learned this from his friend Ahmed Sallam, and this really shows why discussions is very important, and why all these discussions are very helpful. I've been working for a long time, and still you learn and you learn and you learn from your friends, from your previous fellows, from your colleagues. Okay, so here, the active method. So this is your centurion. Usually what happens is you have the injection only activated, right? But now we're going to activate both the injection and the aspiration.
We lose Dr. Sallam right now.
Right, I'm sorry.
It's okay.
So you're going to activate both the injection and the vacuum. And this is a very nice way to start, 330 or 250/30. So you're injecting the oil at a 30 and injecting the aspirating at 250. Now remember, the arrangement is like this, right? So you have the silicone oil infusion, you have the light pipe, and you have the backflush now, which is connected on the active aspiration, like an extrusion, active extrusion.
Okay.
Right? This is the arrangement. Now, what happens is like this. Okay, both are activated. These numbers are very nice. You can always tweak. And this now what happens with the pedal. Sorry, I'll find you. Yeah, let me find you a better video what happens with the pedal. So
okay.
Give me 1 second. Well, there are some questions here if you want to that we answer them as I get the video. I think there's a question about 360 laser or.
I don't see the question.
It's live comments. Do you make lasers 360-degree or around the general the giant retinal tear?
Okay, I found it. No, I don't always do 360.
You always do or you don't do?
I don't always do it. I sometimes do it. I sometimes don't. It depends on the if I can see a pathology around it or not. I don't always do a 360. How about you?
I don't do 360 except really when it's like we had a patient last time who had 19 tears in the retina. So that's ended up being 360 even without me wanting that. But with giant breaks, no, I just lasered unless there's a pathology as well.
Do you do a buckle?
With giant tears, no.
You don't do a buckle?
No.
You don't consider a buckle is a good choice or a viable choice?
In giant tears?
In giant tears, yeah?
No, I don't remove the lens. I don't do a buckle. I don't remove the ILM unless there's an epiretinal membrane.
If you would do a buckle, how would you do the buckle?
I think you need to do a non-high buckle because it may increase the slippage.
Yes, this is what I want people to hear. I want people to know that the buckle itself can induce redetachment, can induce slippage, can open and can invert the roll the edge of the tear. So if you're going to do a buckle, then you will do non-encircling buckle. You do it on the other side, actually not on the tear. You do the other part of the retina that is not detached or torn. This is where you think that there is a pathology that's going to happen because the retina that has been torn and detached, that's fine. So you do a buckle on the other side, or you do an encircling, very shallow buckle. This is what I think. Would you buckle the other eye? We answered this question before, right?
Yeah, I would not, but I mean, I think a buckle the other eye, as you said, I like what you said, is radical, but I feel it's better than laser or cryo, because the problem is with prophylactic laser, and this patient I'm telling you about, 19 tears, is you get the tears on the edge of the laser, and then the tears become posterior, and they are more difficult to manage.
Exactly. We just said that one of the high risks is the cryo and the laser itself. So Dr. Ahmed Mujahid had a question: does inferior giant retinal detachment, or I think he may not dialysis, means the giant retinal tear, change your plan and tamponade?
So I think, so I do one of two things. I do either gas or I leave the PFCL. If it's inferior, I will be more towards leaving the PFCL. If it's severe, I would try gas. The problem is, the main problem what I have is being more like from a cost point of view, the problem is I use PFCL. If the retina slips, then you need to use another vial of PFCL. That's $700.
Yeah.
So this is now, I've wasted $1,500, which actually all what we're paid for in terms of consumables into PFCL, let alone the cost of other consumables. So it's really a cost thing.
So when you use the PFCL, Dr. Ahmed, do you fully fill the eye, or you partially fill the eye, or
again, across the tear and a bit?
So you don't fully fill the eye?
No, like what I showed, I cross the giant retinal tear and a bit more so that it covers the brick. That's it. Oh, when I leave the PFCL tamponade?
Yes.
Oh, when I leave PFCL tamponade, yes, you want to really nearly fill the eye. So as you know, like you cannot see the edge.
Okay. Okay. Well, I did that a couple of times. One time it was good. The other time it was with a giant retinal tear surgery that went completely nice, very nice surgery. And after I did the laser, as I overfilled with the PFC and did my laser. Everything was fine. And I was like, you know what? I'm not going to do any exchange. I'm so happy with this result. I'm going to leave it. And I left the patient on PFC. And I left it exactly for 10 days. And I came back and I had cataract. I had corneal edema. Everything was very difficult. Like I couldn't, it was, for me, it was a surprise. I thought I'm going to come back. I'm going to put gas, or I'm going to put air, and I'm going to be very good. It was a surprise. Like the eye was so angry, and everything was very difficult. And the nice surgery that I had was not there. So, do you think that PFC can have an adverse reaction, or do you think
it's inflammatory, and I think 7 to 10 days is good, really, but it's inflammatory. What I haven't tried, what I would like to try, is to put Ozurdex at the time of PFCL. The problem is the cost and getting that sorted. I leave Kenalog. I think it's a nice way of doing it, but yes, you're right. It can cause inflammation, and sometimes the eye can remain inflamed a little bit even after the removal of PFCL for a few months. So I give them topical steroids for a longer time. If I have the choice and the PFCL is not very expensive, I would try at least one PFCL gas. And if it works, PFCL air. If it works, fine. If it doesn't work and it slips, I'll go back again, PFCL, and leave it.
Okay, very nice.
That's what I would try. I've got the video ready.
Okay, yeah, it should.
Share screen here. Okay, so that's the same video. The oil line is primed now. So I take it out, prime it, put it back.
So let's I know some people will find it difficult to understand. Priming up it means that you're trying the line and you're irrigating in the line, so you can see that the oil is already flowing into the line.
Yes, that's correct. Yeah, the oil is flowing. If the oil is coming out of the line, and then you put it back. And now this is the arrangement, right? So light, and this drawing, this is my case, but this beautiful drawing is from a presentation I did with Abdullah in a meeting. So Abdullah did this presentation, Abdullah Lepen. So here, you have the silicone oil coming like this, you have the light, and you have active aspiration connected to the machine. Right. Now this is, again, and this is a nice drawing where you can see the oil and the PFCL, and Dr. Wael showed a very nice drawing where actually the oil really loves the PFCL, so they join together so quickly and they kick out the fluid. But the point to remember from here is that the backflush all the time is in fluid or in PFCL, right?
Exactly. Okay,
so this is the technique as that happens. And actually, you know, it's a very good point, Wael. I had not noticed why. I know that this is BSS, but I did not really know that it's like a darker ring around it. But you can see here, this is the PFCL and this is the BSS as a darker ring around it. What was the reason it's dark? Why it's dark again?
Because it has a steep angle. The angle is very steep, so the light there's a shadow on the light is being deflected from the surface of the side of the bubble, the PFC bubble.
Okay, that's nice. So here, and I'm now removing the PFCL and the BSS, and if you do it correct, slippage just does not happen under oil. It just does not happen. And then here, so the oil is being injected. The backflush or the extrusion here is always in the BSS or the PFCL. And let me show you this how it happens out from outside. So again, here both are activated. This is nice. This is the foot pedal, and what happens here with the foot pedal is you have a preset. Let's say you have a preset injection of 30. So until you reach the 30, it's linear, and you're just injecting. And then after that, if you press the foot pedal more, the aspiration now kicks in, and the injection continues as well. So you're injecting linear, now you reach the 30. As you inject more, you have the 30, but now the aspiration kicks in. So, and this is the difficult part, that you actually, to aspirate, you have to press the pedal more.
Yeah, it's like Faku. It's like in Faku.
Yes, you're right, that's a good expression. So in a way, you can work with the pedal like an inverted way. You actually, from the beginning, you have the pedal down, where you're injecting and aspirating, and that's what I do. And then if the eye softens, you ease off a little bit, so you're aspirating less. So I work in a reverse pedal way.
Oh, excellent.
So all the way down, and you'll see it again here. So here, as it kicks the 30, look at this, kicks the 30. Now the aspiration is going to kick in as it goes to the 30. Here. And I'm pressing more. And the 30 remains, but the aspiration is now kicking in.
Very nice video.
And now you see what happens on the machine and from outside. And you can see the disc remains pink. So now you're injecting. Right now, aspiration is kicking in, aspiration is kicking in, and the injection continues. And the disc is pink.
ده مين اللي بيصور لك الحاجات الجامده دي؟
Yes, it's because we're working on 3D, so someone from outside and someone on the machine.
It's amazing. It's amazing.
Yeah.
Very nice. Okay, I think, did we cover everything now?
I think maybe we can talk about the tamponade a bit if you want. And also
Yes.
the question about ILM peel.
ILM, do you do ILM peel for all cases?
No. Only if there's a problem, PVR or epiretinal membrane or macular hole.
Okay. Okay. So you don't consider this as a necessary step at all?
No.
Excellent. Excellent. So your favorite tamponade is?
Is PFCL. I just leave the PFCL. If it's a superior, 7 to 10 days. If it's superior, I may try going to air than gas.
You would leave it on air?
Pardon?
You would leave it on air?
No, I go to air than gas, so I leave it in gas. Yeah. Yes. No, not on air. No.
And when would you do oil?
I try to avoid oil in all retinal detachment, including giant tear. In my thinking, okay, oil needs to come back, and PFCL you need to come back, but at least I don't have the, I keep the surgery simple and just leave the PFCL and that's it. But I think oil in giant retinal tear is also a good idea. There's no slippage. It's usually a straightforward technique if you can do a direct PFCL oil exchange.
Okay, so if you leave the PFC, then you leave it for 1 week?
Yeah, I leave it for 7 to 10 days maximum, and then I take it out. And I may leave nothing or leave air.
Well, that's the point. You may leave it on fluid, or you leave it on air, or do you leave it on gas?
No, fluid or air. Usually it's stuck down. After a few days, If the laser kicks in, then it's really stuck down. And I feel it's a nice way. You have a look, you revise your work, maybe add a little bit of more laser, admire your work, and then just leave it on air.
Okay. All right.
There's actually several good papers. One of them is by a colleague from the UK who's also Egyptian called Michael Mikhail. And he showed their experience from Ireland when he was trained. And they had actually very reasonable results and very good results.
Okay, very good.
Yeah.
Very good. What else do we need to talk about? Well, I have one video to show that although it's in the definition of giant retinal tear to have a PVD, sometimes you don't. In traumatic cases or something, or in myopic patients, you can see you're still trying to remove the posterior vitreous. So it's very rare, but it's there. You can sometimes find yourself stuck with the vitreous that you need to start pulling on and remove from the posterior retina. And I think this is the end of my presentation, and I think we've covered most of the topics for giant retinal tear. Is there anything you would like to add, Dr. Ahmed?
No, I was trying to get Michael's paper, but just to code the figures, but I think yeah.
And what is the paper about, Dr. Ahmed?
It's a paper about using PFCL. It's in the eye journal. It's about using PFCL as the primary tamponade in giant retinal break.
Oh, yes, I saw him posting a link for it.
Yes. If you can open it, would be great.
Let me. I don't have it here now, so I can't really find it. So.
Yeah, I think I got it. It's here, and they.
Okay, we can take a couple of questions if anybody wants to ask questions before we wrap things up.
So they had no case of retinal slippage, of course. Their redetachment rate was only 13%, and it was reasonably tolerated. And there are really good papers as well from US and I think Australia or New Zealand where this technique came from. It's a nice way, but it does have advantages and disadvantages.
Well, this is very nice. Thank you, Dr. Ahmed, for a lovely meeting and a very informative videos and a lot of good experience. Everybody is happy here with us with this presentation. Someone was asking a full video of a case. Well, we can find that something like that. We'll post it on the YouTube or something. We don't have the time to.
Yeah, I'll try to find a nice video and edit it. But yes, that's a good point. It's good to see the flow.
And I have to thank Tawfiq for a lot of help in a lot of the cases that I have shown, and he's always the man of the hour. And thank you very much, Dr. Ahmed, and I hope to see you tomorrow. Tomorrow we have another session with Dr. Ahmed and Dr. Tina Badar. We will be talking about uveitis. It will be a clinical case debate. It's a case-based discussion, and we will elaborate on how to think and how to approach cases of uveitis. Thank you again, Dr. Ahmed.
Thank you so much, and thank you so much, everyone. Thank you.
Thank you, everyone, and see you again tomorrow, inshallah, at 9 o'clock.
Yes, inshallah.
Thank you.